Thank you so much, everyone, for joining us. I'm Genevieve Frazier with Rogers Behavioral Health. Joining me today is Dr. Christopher Lowden and Dr. Patrick Michaels to speak about serious mental illnesses. Before we get started, we do want to review a couple of logistics and preview of the format today. The webinar is scheduled for 90 minutes, and to receive CE credits, you must be logged into the webinar for the entire program. Your attendance is tracked via Zoom login and logout records. A PDF of the PowerPoint slides, as well as a list of references, will be available to you immediately after the program via a link within your personal dashboard on ce-go.com. In addition, a recording of the webinar will be published on Rogers' YouTube channel within the next day or two for you to review. Our speakers will have a presentation from 70 to 75 minutes. Following the presentation, I will facilitate a Q&A session. If you would like to ask our speakers a question today, please use the Q&A button, not the chat function, to send a message. You will find this at the bottom of your screen. You simply click the Q&A button on the Zoom taskbar. I will review the questions submitted, and the presenters will address these questions during the Q&A portion of the webinar. Finally, we have enabled closed captioning for this program. At the bottom of your screen, there is a live transcription button. From that menu, you can simply click Show Subtitles to view the audio as text. If you would like to disable the subtitles, simply click Hide Subtitles in the live transcription menu. Now I'll turn it over to our presenters.
Good afternoon or morning, depending on where you're joining us from. My name is Christopher Lowden. I'll go straight ahead. Myself and Dr. Michaels do not have any disclosures for this presentation. Learning objectives today are regarding serious mental illness, to identify at least 2 common functional impairments in people with SMI, 2 medical treatments that improve functional outcomes, and 2 psychological treatments that improve functional outcomes. What we will cover in this webinar is going over the current state of serious mental illness. We'll go give an overview, and then we'll go over psychiatric treatment as well as psychotherapy treatment for serious mental illness. Like I said, I'm Chris Lowden. I'm Senior Medical Director of Medical Staff Wellbeing at Rogers Behavioral Health. Dr. Michaels.
Thanks, Dr. Lowden. I'm excited to be here and offer this presentation today. I'm the clinical director for Rogers in Nashville. I'm a clinical psychologist by training, and father and husband, just like Dr. Lowden. And we're excited to offer this talk to you today.
Thank you. With that, I will jump right in. So serious mental illness, current state. So serious mental illness, and serious mental illness is not a DSM diagnosis. It's a sort of collection of and category of mental illness. It is persistent and chronic. It could be either static or unstable. And so serious, what does serious mean? And that could be different depending on context, depending on culture. So serious, someone who is not able to achieve significant life goals because of deficits due to mental illness. And life goals, those are always defined by culture, whether work, education, where you live, relationships, what's emphasized in your community. So what impacts one person perceived functionality may not impact another person's functionality. And that mental illness, of course, is broad, is a broad term, not any specific pathology. When we think of serious mental illness, we tend to think of psychosis. That's often one of the more outward-facing mental illnesses, and also one of the more significant and debilitating mental illness, but that's not the only SMI. We will focus somewhat on psychosis today, but also keep in mind that we really could be talking about a myriad of different mental illness. So what we know about SMI is that people with SMI, it shortens their lifespan by 8.2 years, just by virtue of being in that category. And that, people aren't dying from the mental illness per se, they're dying from physical illness. And so physical illness accounts for 95.4% of deaths. Physical functioning often resembles a population that is 10 to 20 years younger. Keeping in mind, we're talking about people with mental illness here that are showing worse physical functioning than their peers. And we'll go more into why that is as we go through this presentation. So there's a higher incidence of cardiovascular illness, respiratory illness, GI disorders, neurological disorders, cancer, bloodborne illness, orthopedic illness. Patients with SMI are more likely to be hospitalized for physical health problems and overutilize the ER for physical health problems, not due to their mental illness necessarily. And so there are
Thanks, Dr. Lowden. I'll
yeah, sorry.
The functional impairments in schizophrenia. I want to talk a little bit about why folks with psychosis have difficulty with the sensory input that is being processed. And so what we find here are the functional impairments that folks with schizophrenia struggle with. There are working memory deficits, and these are the moment-to-moment kinds of things that are happening. So for instance, when you just meet somebody and you're trying to remember their name, working memory is helping you try and to consolidate that into your memory. What we end up finding is that people with schizophrenia can be distracted due to hippocampal dysfunction, and this impairs their episodic memory, which is the kinds of things in their long-term storage that lead to the consolidation of the things that are happening in their life. When you take this information together, what you end up finding is that when they continue to process information during new experiences, they use the belief structures that they have created in their mind, and that new sensory information is processed in a way where they are continuing to interpret the information as distressing or perhaps an odd experience. And so what you find is that there are some at the sensory level processing issues, and there are some issues with the top-down processing. As we continue on to the executive functioning deficits on the next slide, what you might find here is you might wonder what contributes to psychosis. Well, a part of this is about the specific biases in reasoning and information processing that folks with psychosis, and how they process that information. A part of this is that episodic memory, again, where they already have belief structures about how information is to be interpreted, coupled with some strong emotional experiences. So if you take this together, let's say somebody has an experience of a hallucination, they're seeing something that other folks may not see, but they're experiencing it. They're taking that as a cue of threat, and coupled with how their belief structure is in their mind, they're interpreting that as something that is really there, and therefore it's stressing. Some of the reasons that research suggests that this continues to occur and why delusional belief formation may continue are there some common reasons or cognitive patterns that people with psychosis rely on. Jumping to conclusions as a cognitive distortion is a very common experience. An externalizing attributional bias, which in other words is an external locus of control and an interpretation of information that's grounded in the world and not in themselves. And as you take that together, that seems to form a delusional belief and keeps that going and alive. On the next slide, we want to highlight the social functional impairments. This is sort of a big plug for the U.S. Surgeon General's report in some way about our epidemic of isolation and loneliness. One of the things that we see that is very common to people with schizophrenia is that they end up withdrawing from society. And so you find chronic isolation and exclusion. That is a part of not only American life, but life across the world for folks with schizophrenia. What this ends up doing is it leaves people prone to processing information or kind of being stuck in their head or having hyperactivity that leads them to have continued psychosis or other experiences that reinforce the belief systems that they have. This is also a big plug for the sort of the plasticity of the mind and the importance of having good connection to the community, because as we connect with other people, we can learn new things and new ways of being. And so another way of looking at this is that continued community inclusion may be an antidote to some of the belief structures that we're talking about taking as deep a foothold as they do. On the next slide, we'll talk about, this is a really beautiful model of how psychosis can develop in individuals and just how it doesn't just all of a sudden come on, but there are risk factors on the left side of the slide that are genetic and family factors. You know, psychosis can run in families. On the bottom of the slide, you see that there is a developmental kind of age trajectory where you look at prenatal development, where people can be exposed to infections like the flu or birth complications. As they continue to move throughout their childhood, they may be exposed to adverse childhood experiences or those ACEs, trauma, abuse, neglect, even moving towards substance use, which may onset in adolescence or may be exposed to in childhood. What we end up finding is this is a complicated picture, but there are lots of factors. As you continue to move up the slide, you see that there are neurotransmitters that may be functioning in different ways than other people. And that may lead to people having psychosis or other experiences. As you move up into the sensory motor and perceptual deficits, people may have a specific bias or pay attention to certain things in the environment that may lead to these perceptions that they're having hallucinations or even that feed delusions. The cognitive deficits that we have already talked about, including memory, sensory processing, and some of the cognitive distortions, and even the executive functioning, may continue to lead people to lack some of the social skills or ability to socially connect. And ultimately, a psychosis can really take a foothold. But what I want you to take away from this slide is that there's a whole host of different factors, and it's really an accumulation of these things over time that lead to psychosis for an individual.
So this next slide outlines a case example for you all. We chose this because it's a good example of the type of patient that we're talking about. And so I'd like you to kind of keep this patient, James, in mind as we're going through our presentation. And I'll go ahead and read it so you can get a clear picture in your mind of of who this patient is. And so James is a 50-year-old African-American man who lives on the west side of Chicago. After graduating from high school, James worked for nearly 20 years as an accounting assistant at a large manufacturing company. He married, had 2 daughters, and owned his own home. At age 35, he began experiencing psychotic symptoms. James told his wife that the devil was after him, and he set fire to their home to drive the devil out. He was hospitalized and diagnosed with paranoid schizophrenia. Although the antipsychotic medication prescribed to James in the hospital helped him manage his symptoms and return to work, the side effects caused him to gain a great deal of weight. He became diabetic and developed pain in his legs and feet. His physician's office was more than an hour away. High crime rates had long ago forced medical providers out of his neighborhood. The physician recommended that James get more exercise and take walks after work. But gang activity on his block made that a dangerous activity. So just keep James in mind as we move forward here. This is an example of the deteriorating course of schizophrenia in patients. What we see is, an initial prodrome where we can see a decline in functioning, and prodrome before positive symptoms of schizophrenia set in, like psychosis, delusions. The patient may go through a series of responses and relapses in symptoms over a period of years. Significant amount of relapses and symptoms can lead to treatment resistance down the road. When I was a medical student and in training on the neurology floors, we often had a saying when it came to stroke patients, that time equals brain. That the more time that goes by, that brain is losing perfusion, there's brain matter loss. Well, similar things can be said in terms of active psychosis and relapse. Active psychosis and relapse is correlated with loss of brain tissue. That is one of the things that can potentially lead to treatment resistance and also just an overall decline in functioning, even when positive symptoms of schizophrenia have improved. Wellness is not just defined as responding to medication or absence of delusions or psychosis. Wellness also refers to the emotional, environmental, financial, intellectual, occupational, physical, social, spiritual domains of a person. It makes up the entire person. Somebody may be experiencing significant positive symptoms of schizophrenia, as an example of SMI, but they may be experiencing positive or negative aspects of well-being in some of these other dimensions. And so it's always important to keep that in mind. What is the wellness in the context of the person that's sitting in front of you, or the person that we're talking about? The wellness of James, for instance, is going to be different from others with SMI. And so there are significant gaps in being able to treat SMI. Very complicated illness. One of those things is access to care. So there's a higher proportion of people with mental illness who are uninsured compared to those without. So people with SMI are less likely to have a primary care provider caring for their overall medical health. They're often screened less often for common conditions, not just due to lack of access, but sometimes due to the way they present in certain places in the healthcare system. A diagnosis of schizophrenia or bipolar disorder correlated with admission to nursing home with more health-related deficiency through government inspection. So those with schizophrenia and bipolar disorder are often finding themselves in nursing homes that are not as quality as other facilities. And so there are different levels of factors contributing to these discrepancies. There's system level factors, and that's the healthcare system, healthcare delivery coordination, how one pays for it. There's fragmentation in the way that healthcare is delivered. Beyond the system is provider level factors. Stigma, stereotypes, prejudice, and discrimination are alive and well, unfortunately, in treatment of mental health. Misdiagnoses or underdiagnoses of medical conditions is very common in people with serious mental illness, as they may not be as outward facing some of the other symptoms that they often or doctors with. And they often are experiencing non-standard practice when it comes to general overall health screenings or procedures supposed to, whether that be due to access or due to the provider themselves. Procedures, medications, the same. At the individual level, someone with SNI can experience cognitive and social deficits that Dr. Michaels was talking about, and overall worse physical health. And then, of course, there's overall social determinants of health, things that affect health, like poverty, homelessness, incarceration, being a racial or ethnic minority. Dr. Michaels?
Thanks, Dr. Lowden. As Dr. Lowden was talking about some of the provider level factors, I just want to highlight one of my favorite things, which is the SAMHSA wheel. It's really important that how we do the work that we do and deliver care to make such a difference. I think some folks talk about emotions as being contagious. Miller and some of his motivational interviewing work would talk a lot about how people can understand whether we see hope for them just by how we give off our emotional responses. And our folks with schizophrenia are really no different. So this is a big plug for why we should deliver authentic patient-centered care. And a big part of this is identifying the strengths and resources and opportunities. Everybody has got something that they are good at. I remember one of our favorite patients that I've worked with was really good at art, and he would get lost in the flow of that and spend many hours doing it. And he was great at that. And so, as people find the things they're really good at in their life, we can help them with the things that they're not so good at. And as Dr. Lowden was talking about the wellness wheel and the 8 different factors that go into that, a part of the thing that we can help them take an appreciation is that physical and mental health really go together, and that intersection as a whole being is really important. And so empowering people for the self-management of their medical conditions can allow their mind and their brain to do the things that help them engage in life with the sort of agency they want across many different things. We really want to encourage people to, kind of find their tribe, find their people in the world. Everybody's got people that really want to be around them, that share their interests, whether it's art or knitting, or maybe they like to cook. There are lots of different ways where you can connect with people. In recovery, there is the idea of the dignity to fail or the dignity to take risks. I think in the past, some of our models towards treatment have tried to prevent people from taking risks and have said, just stay home, don't do anything stressful because you might have a relapse. But that really doesn't give people the opportunity to engage in their community and afford them the learning opportunities and to connect with different people and learn things. And so we want to really deeply understand the values that each person has, because then we will know how to help them make good decisions together with them and really empower them. And this is really how we provide compassionate care for these types of patients. On the next slide, we'll talk about SAMHSA's 4 dimensions of recovery. This is how we can focus our treatment and our work along with our patients and having a good collaborative care. Most folks are probably familiar with Maslow's hierarchy of needs. We want to focus on the stuff that's most important. Certainly, we're not going to do thought challenging when somebody is homeless and doesn't have a place to live. Focusing on the stuff that's most important to them is where we want to start. This also recognizes, again, that physical health and mental health have to go together, and that we are whole beings that have to be cared for in a whole way. Having meaning and purpose in our lives is this 3rd area. Lots of folks with serious mental illnesses don't have the opportunity to work or go to school or to be involved in things that they find truly meaningful. And so we want them to be able to find a place in the world to continue to grow and develop and learn and develop the skills that they want to engage in the community. And that's really the last big plug here is having a place, whether it's a house of worship, whether it's going to volunteer at the YMCA, being involved in volunteering with the soup kitchen, something in your world to have people around you who can love and care about you, so that you have a good sense of community. And so as we guide our treatment, it's really about each person has strengths and a place to be, and we want to help We want to help know them at a deep level and help them connect with those parts of themselves. On the next slide, we can talk about an individual level solution. I would suppose that folks are familiar with peer support specialists, health navigators, community health workers. This originated out of cancer care in New York many years ago. And it was in recognition that our healthcare system is large, can be confusing even for the most well-educated of us. And this also recognizes that people with cognitive deficits, executive dysfunction, they may not be able to know what to ask during meetings with their primary care doctors, with their cancer doctors. They may not even know how to walk around the hospital. And so by having people that know the system and know what to do and are on their side, kind of on their team, if you will, they can really ask good questions. And so one of the other solutions that is huge here is these health navigators and peer supports. Also a plug, there are national and international associations of peer supports. And so there's a lot more recognition and certification, for this as a solution.
Okay, next I'm going to talk about psychiatric treatment and best practices. I'm going to veer away from this being a pharmacology talk. I mean, we're going to talk about medications for SMI, but I want to just talk about the overall attitude towards medications and the context of medication treatment in SMI. So I'll go ahead and move forward. So medication treatment for SMI. Medications are often necessary and effective for many mental illness that impairs functioning. Medications need to be a mainstay of treatment. That's not to say it's the only part of treatment, but medication plus other facets of treatment are often the effective ways to achieve functional improvement. So you can see symptom reduction, improvement in daily functioning, overall wellness. But our medications are not perfect. There can be costs of medications, not just monetary costs, but a lot of our medications can cause significant side effects, can also contribute to physical health issues, and then need additional monitoring in order to make sure that patient who is taking the medication stays healthy. So I'm going to be talking a lot today about the class of medications and psychotics. It is a very broad class of medications within psychiatry, and it's sort of a multi-tool. There's indications in psychiatry for antipsychotics in schizophrenia, schizoaffective disorder, bipolar mania, bipolar depression, unipolar depression, OCD, and autism. Just because they're called antipsychotics, we're not always using them to treat psychosis. Sometimes they're mood stabilizers. Sometimes they help with depression. Sometimes they help with behavioral agitation. And there's often a lot of off-label uses for antipsychotics as well. They may not be FDA approved for a certain treatment, but there's evidence to support treatment using the medication in that way to treat an underlying symptom or underlying illness. So when we talk about SMI and we talk about medications, we are often including antipsychotics in that discussion. And they, like I had been saying, they can cause a lot of side effects. People who are taking antipsychotic medication have a greater risk of metabolic syndrome, meaning higher cholesterol or insulin resistance that can dispose somebody to diabetes, greater risk of obesity, cardiovascular disease, sudden cardiac death, myocarditis and cardiomyopathy, hypertension, diabetes, pneumonia, to name just a few. And so here is a slide that goes over data on many of our antipsychotics, each of the initials that you see along the left column under each of those categories is an antipsychotic. And you'll see in terms of them negatively affecting weight gain, the evidence is there. Anything to the right of the line is something that is going to affect weight gain negatively and lead to positive weight gain. Drug-induced Parkinsonism is definitely a potential side effect for antipsychotic medications. They can induce Parkinson's disease-like symptoms. And you'll see the medications that are to the right of the line there have a higher risk of that side effect. And then hyperprolactinemia is also a side effect of many of our antipsychotics. With those 4 medications at the bottom being the biggest contributors. And prolactin is the hormone in the body that induces lactation and the formation of breast tissue, which can cause complications in females, but also can cause significant complications in males as well. And if you're stimulating prolactin, you're also potentially increasing the volume of certain gland in the brain, which is never a good thing. So these are important side effects that people need to be monitored for. And so when we're talking about this and we're talking about side effects, the question often comes up, why would I take a medication that has all of these side effects, that has the potential to cause worsening health outcomes in other ways? I thought you were telling me that the SMI in and of itself can lead to worsening health outcomes. So I want to explain that a little bit further. There are also consequences, and I guess, quote unquote, side effects of psychotic relapse. And we already talked earlier about how loss of brain tissue and can occur in psychotic relapse, and that can also lead to treatment resistance in the future. Consequences of psychotic relapse also include overall disability and functioning. Can increase the risk of incarceration and criminalization, suicide, homelessness, early mortality. PTSD, patients with psychotic relapse are more likely to be in a situation where they experience a traumatic event leading to PTSD, hopelessness, depression, demoralization, and also family burden and separation from family often occurs. Isolation from family often occurs with worsening illness. And so we take a look at antipsychotics. We look at their side effects, but we also look at their positive effects. This data is from a study done in 2017 that looked at antipsychotics in general compared to placebo. And you can see there that there was a significant more improvement in symptoms of schizophrenia. We saw a significant improvement in at least minimal improvement, and then also significant in the amount of patients that experienced much improvement. When we're talking about that improvement that's measured on this slide, we're largely talking about improvement in positive symptoms of schizophrenia, like psychosis, delusions. And here is another slide that also shows more down to the specific antipsychotic itself, that just as those on the antipsychotics you saw on the other slide were more likely to experience those side effects that were mentioned, patients on antipsychotics are more likely to experience symptom reduction. And not only those positive symptoms that I mentioned, but also negative symptoms as well. By negative symptoms, I mean cognitive issues, emotional masking, anhedonia, difficulty with communication, often things that are apparent but not are sort of like what we necessarily think of off the top of our mind when we're thinking of schizophrenia. I'll draw attention to under positive symptoms in the upper left-hand corner, clozapine, that medication at the top. It shows a significant reduction in positive symptoms when you're comparing them with other medications. And so more on that in just a moment. And then here we have another slide that gives an example. Not only are we seeing a reduction in symptoms with antipsychotics, but we see an improvement in quality of life there with the top diagram, and then also social functioning there with the bottom diagram. So if you're talking about, the different domains of wellness, now if we are just focusing on, psychosis as a symptom, we're missing the boat. We also want to look at those other domains of wellness. Here we're able to measure to a certain extent quality of life and social functioning, which can lead to overall improved wellness and better health outcomes. And so it's important to note that with antipsychotics, the medications work. They can work for positive and negative symptoms. They can improve social functioning, quality of life. When you look at populations who take antipsychotics for illness compared to those who take placebo, more people are going to stop the placebo than stop the antipsychotic. And that voluntarily. So patients are going to choose not to take a placebo because they're experiencing, with the idea that they're experiencing less of a positive effect from it. They're going to continue to take the antipsychotic for longer periods of time because they're experiencing that positive effect. And we know that side effects are common. And more on this later, but when we come to side effects, we want to be upfront about them. We want to talk about them. We want people to understand that they may experience side effects. If they experience side effect, here's a way we might deal with it. Here's a way we might do. Here's the way we might adjust things. So I spoke a little bit about clozapine. I think clozapine is a really good example of the risk benefits of antipsychotics. So like I was saying, clozapine has been shown over and over again to be one of our most effective medications in treating psychosis and treating schizophrenia. That also comes along with it is that it has not one, not two, not three, but 6 different black box warnings on it for negative health outcomes, severe neutropenia, that makes it necessary for people who are on clozapine to be monitored with regular blood tests, orthostatic hypotension, risk of seizure, risk of myocarditis, cardiomyopathy, increased mortality in elderly patients with dementia-related psychosis. And so this leads me to talk about one of my favorite studies. It talks about antipsychotics in general, but also specifically clozapine. So this is a study that was done in Finland, comparing 66,881 patients with schizophrenia to the total population. So a large number of patients. What they did here was they were able, because of national medical records, they're able to look back and get data on all-cause mortality of patients with schizophrenia who had used antipsychotic medications, and those who had not used those medications. And so, of all this antipsychotics measured, clozapine is associated with the lowest risk of mortality. So, we're seeing here that we know from research that clozapine is one of our most effective medications. And then we're also seeing in this study that it's associated with the lowest risk of mortality, even though there are those number of significant side effects and black box warnings associated with them. And so long-term exposure to any antipsychotic was associated with lower mortality than no drug use, and drug meaning the antipsychotic medication. And there was an inverse relation between mortality and duration of cumulative use of antipsychotic. So it tended to be that if in general in the population, mortality was reduced when a patient was on their antipsychotic over longer periods of time. That was the trend that was seen. And just as note, I bring up this not to minimize the potential side effects and not to minimize the seriousness of them and the need for monitoring, but that they exist in the entire context of treatment and what you can expect in terms of improvement in functioning and things that you need to watch. We've talked about overall the argument for widespread use of antipsychotics, which I believe in. One thing that the population with SMI struggles with is taking medications consistently. Relapses are often because patients are without their medications or because of the side effects that we talked about, they stop taking their medications. One way in which we have to address this is by use of long-acting injectable medications. Medications that when they're injected either, via needle, either subdermally or intramuscularly, they're released in the system over a long period of time. There are formulations now that can last even up to 6 months. What we see with patients with long-acting injectables is that there's fewer emergencies and abrupt relapses. There's lower risk of overdose with medications, improved patient-physician satisfaction. No need for daily dosing. So obviously that improves adherence because you can give it once and then it's there for a longer period of time. And it's not being absorbed to the GI tract. So we're sort of leaving that piece out of it. And that's not to say, long-acting injectables, this is something that is discussed with a patient ahead of time, that you talk about and you say, hey, here's an option for your treatment. I know you have issues not taking medications. That has led to negative things in the past. Would you consider a long-acting injectable medication? That's a discussion that I've had with patients and probably could be had potentially more often in the world of psychiatry. Here's an example of different long-acting injectables. You'll see there that some of our older antipsychotics have long-acting formulations as well as some of our newer antipsychotics. The case for long-acting injectable medication. This is a study done with one of the antipsychotics, risperidone, just showing the reduced proportion of patients in this study who relapsed on the long-acting injectable form of risperidone compared to the oral formulation of risperidone. And this was over the course of a year. Now, I've told you all these things about our antipsychotic medications and all of the side effects. There are lots of newer antipsychotic medications in development that utilize different mechanisms in terms of their use, showing some very, very positive and exciting results in terms of treating symptoms. Some of the mechanisms of action are listed right there. By and large, in these studies right now, they're finding that these medications are well tolerated, not finding drug-induced Parkinsonism, not finding weight gain, not finding sedation, sexual dysfunction, metabolic effects. They're having the positive effects in the illness without having the negative. Of course, these medications are still in clinical trials, not yet released, but I wanted to mention them just because it's a potentially really exciting future for treatment of psychosis and use of antipsychotics. Other medications, of course, we did focus a lot on antipsychotics, like I mentioned, but there are many, many different medications in the treatment of mental illness and serious mental illness. This here is just a very short list of them. I also want to just mention sort of some of the other future directions, medication directions that we're seeing in terms of treatment of all kinds of mental illness. Ketamine is out there. IV ketamine is not FDA approved for depression. However, a recent study just came out regarding ketamine showing that with the conclusion that it was not inferior to ECT. This is sort of a benchmark because ECT has always been shown in comparison to other treatments as the gold standard for treatment of depression, certainly treatment-resistant depression. This is the first study that had to find something that's not ECT that is coming up with similar outcomes. There is an FDA-approved form of ketamine, S-ketamine, which is administered in a nasal spray that is utilized right now. There's some other future directions, things that people are looking at that aren't just necessarily, rumors. MDMA, which is the active ingredient in ecstasy, is being studied in psychotherapy assisted, MDMA assisted psychotherapy for things like PTSD. Psilocybin, which is the active ingredient in mushrooms, which is a hallucinogenic, also showing really significant improvement in people with depression. Of course, these medications are not yet approved. It's not yet shown that they are safe to be utilized widespread. This is not a commercial for them. It's just really to mention that these things are out there and some potentially exciting research that's coming out with them. And so I want to end this part of the talk just talking about medications in general and the importance of shared decision making with patients. We're far from the idea of take 2 pills and call me in the morning type of mentality when it comes to treating mental illness. It's really a shared decision. It's really the patient and the practitioner in a partnership with the shared goal of the patient's improvement and wellness and the shared decision making. It's the provider, the practitioner's job to discuss why they've come up with the treatment plan they've come up with, the different side effects that can be encountered, what we could do in case of those side effects, and educate the patient so that at the end of the day, the patient is making a choice for their own treatment based on the information they have from the expertise of the practitioner. So the provider and patient are both active participants. It's a two-way exchange of information, bidirectional expression of treatment preferences. Because as a psychiatrist, I can always guess at what the goals of a patient's treatment are. But until I ask and the patient actually tells me what their specific goals are, I don't know, and I don't know how to address those particular goals. And through these discussions, we can lead to a consensus on treatment implementation. Shared decision making leads to a greater sense of personal control and empowerment from the patient. Lower levels of persistent concern regarding illness and symptoms leads to an improvement in patient knowledge about their own illness and how to take care of their own illness. And it increases patient participation, which leads to improved outcomes and adherence. So I will pass this back along to Dr. Michaels to wrap things up with a summary of psychotherapy treatment best practices.
Thanks, Dr. Lowden. I appreciated the discussion of shared decision making quite a bit. We know that treatment dropout is a serious thing that a lot of patients face. Recent SAMHSA data from a couple of years ago even suggests that about a third of patients are avoiding treatment. So certainly the quality of care makes a big difference. On the next slide, I wanted to talk about recovery-oriented care, and we've talked a little bit about the SAMHSA principles. But recovery-oriented care is an engaging and non-judgmental way of being. And I would think about this as a lot about us doing our own work and figuring out how we show up in the rooms with patients or clients and how we interact with them. There's a lot of interesting work about how providers of mental health services have just as much stigma as the general population. Great study from Schulz in 2007 that shows that providers are about as stigmatizing as the general population. And of course, we are a product of the cultures that we grow up in and learn and develop. But this is also a large plug for why we need to continue to do our own work, grow our understanding, have an open mind, and learn more about our own ways of being in a self-reflective way. The second principle here is really acknowledging this aspect of hope that individuals who have psychosis can and do recover. One of the things we'll look into in the next few slides is that just because folks are experiencing psychosis, that doesn't mean they're going to be distressed and necessarily become very socially withdrawn and avoidant. Some folks are with treatment and new ways of learning how to engage and have a relationship with those experiences can actually stay in circumstances. And so we need to take a look at how, what our assumptions are about what psychosis means to these folks. The third point here would be that care is really self-directed. And we talk a lot about why treatment plans need to be, owned and a true collaboration. But if, as providers, we are telling the patient what they're going to do, certainly psychological reactance is going to become a major factor, and patients are going to be much more likely to reject being involved in care. And so having shared goals that each person is truly invested in is really important. Over time, models have evolved. We've moved from a compliance model where the doctor told the patient what to do, and as long as the patient did what the doctor said, everything was fine. Our more current model is one more of self-determination or choice, which this more looks at the fact that people are dynamic and they may have a hot and cold emotionality. And so if you give them the same decision with even taking medications 10 days in a row, they may make different decisions on different days for different reasons. And so what I want to emphasize is that people are going to make different choices on different days. It's not that it's a one and done sort of choice. But as we seek to minimize the power hierarchy that we have with folks, because we each bring an expertise to the table, we can get folks to buy into what we're trying to help them accomplish and what these treatments can help them do and function in their life. The next point here is that the experience of psychosis can be understood. When we look at it as something that doesn't make any sense or that there's something that somebody is damaged, we're not going to be able to provide them a sense of hope. And as we look at a person as a whole person who's having these experiences, we can look at them as part of the continuum of human experience. There are people who have experienced psychosis who don't have schizophrenia. Certainly, I think one of the classic examples is if you are sleep deprived long enough, many folks, or at least some folks, will experience some psychotic experience, perhaps. And so it is something that's available to everybody if you want to look at it that way. But moving beyond that, it's just something that, that it can't be understood. It would be helpful. The last point here is that recovery can be painful, and there are a lot of ups and downs. I think we would like to assume that recovery is a straight line of, linear progression through functional improvement. And I think there's lots of cases that folks can even talk about on the call today where that's not really the case, whether you have schizophrenia or psychosis or trauma. This is really hard work. And I think as when we come and have a compassionate approach toward therapy and recovery with folks, we can help them really embrace the difficulties that they're facing to kind of continue on despite the challenge. The next thing I wanted to talk a little bit about is how can we really understand somebody's psychosis? And so I have a number of students, and sometimes they ask me, well, how do you get someone with a delusion to change it? I think the simple answer is that's not always really very feasible. But what I want to emphasize here is that people don't just advertise their delusions. They don't advertise their psychotic experiences. They know that those things are stigmatized. But a lot of open-ended questions, and you can take these as an example of how we learn more about somebody's experience and their emotionality, as well as how that is within their cultural context to learn more about what they're experiencing and if that is something that is kind of within their cultural norm. Dr. Lowden talked earlier about James and driving the devil out. And I think sometimes things can become really difficult and challenging when we're facing the nuance of how is this religiously oriented and how do we parse out what is within the religious cultural norm and which parts of it are not. But these kinds of questions can really allow you to even develop a tentative case conceptualization and get really good collateral information from other people in a person like James's life to learn about what is a part of their culture and what is not. On this next slide, Rogers in general is a major advocate for measurement-based care. I subscribe to that, and I just want to give you a couple of examples to show you that there are some really nice measures, and this is just a short list of a few ways to examine psychosis. You know, certainly as we're trying to understand and have good questions in the moment, sometimes we don't exactly know what to ask. But there are interviews that providers can use to learn more about the positive and negative symptoms of schizophrenia or that are coming along with psychosis. And there are also ways that we can get patients to tell us more about some of their experiences, their delusions, their hallucinations, the beliefs about their voices, and even some of the insight that they're experiencing. As we've talked about earlier, the executive dysfunctions that come along with this may make it hard for them to understand how to interact and have a relationship with these types of experiences, like the hallucinations and delusions. But overall, when we have a really good assessment and a really good understanding of how these things are occurring for that person, then we can know what to do with them. So ultimately, the appraisal of these psychotic symptoms will be able to help lead to people's, whether they have really a lot of distress from them, and then how much disability and functional impairment will result from those psychotic symptoms. I want to talk a little bit about treatments, but I purposefully talked about thinking about how we engage with people first. And that was partly out of homage to stages of change and motivational interviewing, because if we meet somebody and we talk to them about treatment and they have no buy-in and are pre-contemplative to the hallucinations or delusions being of a problem at all, we're not going to be on the same page, and the treatments that we offer are not really going to be very helpful for people. So I really wanted to talk about that first, because I think us understanding what we can offer somebody and then introducing it, through ideas that they can, grapple with and decide upon with the self-determination is a big point. There's been a lot of great work that has been done about psychosocial treatments for people with serious mental illnesses. I've separated these out into individual interventions and community or system interventions. One of the things I want you to understand is that there are lots of different things. We have, social skills training. We can teach people how to do independent living skills. We can do CBT. We can teach them how to use medication boxes, all kinds of different things. And another couple slides, the items with a star we'll talk a little bit more about, but it's beyond the scope of the talk to talk about each of these in extreme detail. On the right side here, I just want you to understand that the community supports something like early intervention for psychosis is actually going to incorporate a number of the individual interventions, including some of the family. So it's more of a package intervention. And so as we move to the next slide, thanks, Dr. Lowden, we can talk about why some of these may have greater impact than others. This is a really nice meta-analysis that was done. This is of over 200 trials and about 24,000 patients. So a lot of folks have contributed to this. One of the things I want to point out is that while we have categorized even things like assertive community treatment and cognitive behavioral therapy, certainly there's not one single protocol that has factored into that. And so, nor one research group. So while you see low and moderate outcomes or positive outcomes for these different treatments, what I want to emphasize overall is that there are still positive things that are happening for folks that are engaging, and a lot of these studies are taking intent to treat. But overall, there's a lot of hope for folks with serious mental illnesses to find a treatment, whether it involves family and significant others, to help them find what they're looking for to accomplish their goals and get back connected into their community. Thanks. On this next slide, this talks a little bit more about what these individual interventions are. I'm sure folks are familiar with some of these, and we can talk more about them on the next slide. Well, the next few slides, rather. One of the ones folks may not know quite as much about is cognitive adaptation training. And for some folks with more severe mental illnesses, they may be more functionally impaired in their homes. They may have difficulty completing activities of daily living, even things like, brushing their teeth or, taking care of, making meals and those kinds of things. So there's really, depending on how severe people's mental health conditions are, you can really tailor treatment to really helping them accomplish their goals. Let's go to the next slide. These are some of the community and support interventions. The assertive community treatment is a really nice treatment. This actually involves a team of professionals, psychologists, psychiatrists, social workers, peer supports, and one of the main goals here is to try and help people stay out of the hospital and in the community and engaging in different activities. So we bring the care to them. Early psychosis intervention is one of the biggest gold standards for how we can reduce some of the brain tissue loss and some of the other significant relapse problems that Dr. Lowden has talked about earlier. Early psychosis intervention has been linked to much more significant outcomes. The belief systems, as we've talked about, the developmental nature of this, have much less time to kind of soak in deeply into people's belief structures, and so it's a really nice way to take psychoeducation, cognitive behavioral therapy, family interventions, and really provide a good environmental support system. Family support, certainly talked about in early psychosis intervention as well, really allows people to, learn how to understand what people are going through, help them provide, greater insight and judgment and feedback to help them really focus on their recovery goals and plans. And certainly the general public knows quite a bit less than mental health providers about the course of these illnesses, what to expect. And for some folks, it can be really frightening based upon how much or how little they know about these conditions. I just want to also talk about support employment. There are other support interventions as well, like supported education, supported housing. We've moved in supported employment. There's lots of great work that's been done over the last 30 years to help people find not, sheltered workshop employment, but competitive employment in the community. And then this would be a great way for them to have that meaningful community involvement and the opportunity to meet people who are not necessarily in treatment, but people in kind of like in the regular world to have new relationships. This allows people to have follow-along support over time, and people who have been involved in this meaningful work can thrive much more than just, kind of staying at home and kind of being socially withdrawn. Thanks, Dr. Lowden. I want to talk about social skills training. Prior to Rogers, I worked at the VA hospital in a psychosocial rehab center. I went through the consultation program to do social skills training. This treatment is actually a lot of fun to do as a facilitator, and you can co-facilitate with another practitioner. Christine and I had a great time with this. You end up finding folks who have some social skill deficits, And what we end up doing is we establish, their collaborative treatment goals, whether they want to, go back to work or learn how to find friends or even communicate with their family or other people. And we would design a curriculum, over one of our quarters and help them to learn the skills that they would need so they could function or interact with people differently. This is a very positive, strengths-focused, treatment. They're looking for, not only are the facilitators practicing the skills themselves, so we're modeling behavior, and the participants in the study are actually able to give the facilitators feedback. So we are kind of leveling that power hierarchy and being vulnerable in those moments as well. So they could say, hey, you could give more eye contact, or you could have greater posture, or you could have said this differently. It's a very positive way of delivering care. And then through repeated practice, we are sort of overlearning things in order for folks to learn new skills. If you go to the next slide, we can talk a little bit about some of the social skills training that curriculum. This is this required about 6 months of consultation to become like a certified trainer in. These are some of the some examples of some of the things that folks can learn. What I want to point out here is that we are learning things all along that the wellness parameters that Dr. Lowden was talking about earlier. They teach skills about how to advocate for side effects with your psychiatrist. They can teach you about how to go ask for job applications, ask people to use condoms for, sexual well-being, talk about refusing substances, all kinds of different things. And some of the most basic are even conversational skills, how to start a conversation, how to end a conversation. And of course, one of our favorites was when we would engage in giving and receiving compliments. And of course, everyone benefits through practice. And so one of the things we would notice is that even the staff would give each other more compliments after going through the compliments role play week, because then we were more primed to do that. So these are skills that can be good for everybody. Moving on to the next slide, I want to talk about one of Beck's last works. This is recovery-oriented cognitive therapy for serious mental illnesses, and this was done in collaboration with the VA and some of their psychosocial rehabilitation and recovery centers. And one of the things that they end up focusing on is not just talking about psychosis and how to navigate that, but they really have a nice case that they talk about, a case of Jackie, who's a person who's been in the psychiatric hospital for about 25 years. And they begin to assess and establish a relationship with Jackie. They get to learn that, she has an interest in jewelry making. And over time, they continue to integrate some behavioral activation. They, on the unit, help her learn how to make jewelry with other people. So they have, they've identified her aspirations and finding some meaning behind those. And then they continue to break down those goals throughout this book. And they talk about how to eventually get Jackie out in the community and even being able to sell some of her jewelry and being involved and being more included in the community. So one of the big benefits of this curriculum is that it's not necessarily focused on getting rid of psychosis, but it's about helping people being integrated into the community and having meaningful activities that can help them generate some of their own, well-being through engaging in positive activities. It's the curriculum is a couple hundred pages. Definitely very interesting if you're interested in learning about serious mental illnesses and how to begin working with folks and integrating in some of these principles that we talked about from SAMHSA. On the next slide, we'll talk about cognitive behavioral therapy for psychosis. If the treatment goal was to specifically help people navigate how to have a better relationship with their psychosis, these are the main facets of what you would end up focusing on. Certainly having a really strong therapeutic relationship is pretty important, and we've talked about that already. We would want to think about how to assess and really understand about some of their experiences, some of those psychotic things, and really how they're making these in the moment how they're connecting some of the perceptions and appraisals, and really having a nice case formulation to understand how those things are occurring. So there's a big plug for a case conceptualization and really understanding how those ABCs interface with some of the safety behaviors that people are experiencing so that you know what to target in CBT for psychosis. A part of this would be also talking about the biopsychosocial model and really providing some good education. The experience of trying to normalize psychosis is to think about that other folks in the community who do not have schizophrenia or are diagnosed with psychosis could experience psychosis, at some point during their life. And so we want them to have a relationship with psychosis, since it may be an enduring thing, that is not one of frustration or is frustration with the self. So the goal is not to get rid of psychosis, but to learn how to live with it and with these experiences in a different way. And if you want to think about it, it's like this psychosis may be a part of me, but it's something that I can learn how to befriend and connect with and have a different relationship with, rather than being frustrated with it. A part of this would also be to try and develop some coping strategies to reduce the stress that is experienced in connection with hallucinations and delusions. And these are a really nice way to do some reality testing experiments. As folks may know, Rogers is very well, uses a lot of treatment for OCD that's based on exposure and response prevention. In CBT for psychosis, they do talk about using some forms of exposure hierarchies, similar to what we do for our OCD folks, to design experiments for reality testing. And so there are ways to ask folks, what do you think is going to happen when you go out in the world and the headlights are blinking at you and you are assuming that people are following you? Let's have that experience happen, and then let's see if we can generate some alternative hypotheses about why that is happening, as an example. And then finally, and of course, this treatment is somewhere between 6 and 9 months, depending on the frequency of it. So it is a significant amount of time. But then the last piece would be to focus on consolidation of the gains, making those therapeutic skills durable so that folks are able to accomplish that. We have a couple more slides to go through, and then I think we'll be on to questions. CBT for psychosis is not without its critiques. Certainly there is a acceptance commitment therapy for psychosis, and that is another avenue that people can experience. Just want to emphasize, or at least mention to folks, that there are some new therapies that are being piloted right now for ACT and compassion-focused therapy, for example. And these are trying to find ways to integrate mindfulness and acceptance to help people with psychosis have a different relationship. But there is more research evidence needed to focus care for people to know that it works well. The last curriculum that I'll talk about is a free SAMHSA curriculum. It's available. It's about 300 and some pages long. This is a psychoeducationally based curriculum. It is a standard of care that has been used in a lot of psychosocial rehab centers. And they focus on teaching people about what recovery is, offering myths and facts about what mental illness is, talking about the stress and vulnerability hypothesis, the importance of having a social support network and how to involve family members in your care, how to use medications effectively, the importance of substance use or non-use, and how to focus on reducing relapses, how to cope with stress, and getting your healthcare needs met within the system. One plug on that is if you're interested in learning more about recovery-oriented care, this would be a really nice curriculum as well. It has a lot of really nice facilitator notes about how to integrate motivational interviewing, cognitive behavioral therapy strategies, modeling, and psychoeducation, and how to help even establish SMART goals with people so that they're bought into treatment. The last thing I want to talk about is a recent article that came out on the Monitor in Psychology, and this example comes from an October issue. And the reason I'm bringing this to your attention is just to emphasize that even in today's day and age, with a lot of our focus on cultural humility, these are still things that are happening. So in this article on Native American health and how to provide care to Native American patients and being sensitive to their needs, this talks about a Native American healthcare providers. We assume patients, may be exhibiting mental illness or substance use, But in reality, there's a great example and in here that talks about a patient who's struggling with grief and looking towards the, outside and looking at the birds and the trees and getting, comfort and support from them. Now, depending on whether you're in an individualistic culture or a collectivistic culture, you may view this differently based upon your spiritual traditions. And so in this article, they talk about how the psychologist had to intervene with the medical team and say, hey, look, I understand much more about this as a Native American myself, at least as the psychologist in the story is, that this is not a psychotic experience. This is actually within the cultural normative experience. And so, don't diagnose them with schizophrenia and offer medications in this moment. All right. I'll turn it over to Genevieve for questions.
Thank you so much, Dr. Michaels and Dr. Lowden. So yes, we will enter now into the Q&A section of our webinar. Again, please use the Q&A button, not the chat, if you'd like to submit your question. We will be combining similar questions, and we will go through as many as we have time for the remaining of the session today. And if we don't get to your question, please feel free to send an email to webinars@RogersBH, and we will follow up with you. So thank you so much for your fantastic questions. We'll start off with a question from Casey. I'd appreciate each of your perspectives on how autism may or may not relate to the concepts that you've been sharing. Do either of you feel that there are ways to differentiate psychosis from autism symptoms or characteristics?
That's a really good question. There is some overlap in terms of autism and schizophrenia illness. And when you talk about the negative symptoms of schizophrenia, part of that is sort of like a lack of emotional reciprocity that you can see in autism as well. And certainly in autism, you can see sort of a rigidly held beliefs that are very adhered to, which can sort of sometimes look like a delusion, but it's not a delusion. Certainly in schizophrenia, you can, and then also, each syndrome has its own separate characteristics and symptoms. And so I think autism can be, a good example of a long-term illness that can decrease functioning, but then can respond to certain types of treatment. So I would say that there's some similarities and there are some differences. But yeah, I think with both, you do get you can have a certain degree of loss of decreased functioning, I would say, and while they have some similarities, they can be also very, very different.
Thank you, Dr. Lowden. We had several questions about the importance of family involvement in treatment with individuals with SMI. One of them is from Liz. I work for a police department, and I often assist families with loved ones who have serious mental illness and are not wanting treatment, but they are also not living life in a safe way. Thoughts or advice on how to help a family and a person with SMI navigate safety, independent living, and possibly involuntary hospitalization to stabilize. There was also some questions around navigating HIPAA and patient privacy.
Dr. Lowden, I'll talk about wellness recovery action planning in this moment as something that folks may be interested in learning more about. Mary Ellen Copeland has a wellness recovery action planning program that helps individuals kind of struggle through that, but it is these are plans that people make to prepare for relapse and rehospitalization. it may be useful to know, the program essentially looks at like 6 things. It looks at, what people are struggling with in terms of their daily stressors, when things are getting worse, how social supports can be involved, and then what medications or preparations need to be made for rehospitalization, and then what preferences are for the individual when they're rehospitalized. I would think if you took that from the family member's perspective, you could ask questions about saying, hey, we've recognized you've been hospitalized these different times. What would you like us to do, or how could we plan for when the next hospitalization is? And maybe through time and enough hospitalizations, the person would start to have some more insight, so the family could be more involved in care. But that might be one avenue to have some concrete plans for when it happens, rather than just surprise, here it is.
Thank you, Dr. Michaels. We also had several questions about medications. And so Dr. Lowden, one is, many psychiatrists are using long-acting injectables as a first-line treatment, and LAI clinics are popping up in several states. What are your thoughts around this?
I think there's some evidence to support use of long-acting injectables with first treatment or first hospitalization and supporting some improved outcomes. Like I said, it is a potential convenient option for our patients, and as long as we're discussing that with them, that there are pros and cons, and that this is something that could potentially be very beneficial to them. I don't see any problem with that type of treatment becoming more prevalent.
Thank you. And to piggyback on that, for the long-acting injectables, what is the treatment for akathisia with long-acting injectables, since it is a severe suicide risk?
Sure. So when we're using long-acting injectables on patients, especially if we're using it for a new medication to them or for the very first time, we're wanting to take a period of time where we're making sure that they are tolerating the oral medications first. I did actually run into a patient with this specific concern. He was hospitalized, started on a medication, agreed that he did seem to tolerate on the inpatient unit. He then agreed to long-acting injectable, which set off a month of akathisia for him. And what happened after that was he was so he's so turned off by that experience, and how could you not be, that he isolated himself from mental health treatment after that. And so, it is a potential negative outcome. There are treatments for it. There are medications that we can use that can decrease the symptoms of akathisia. But in this specific patient's case, he was so turned off by his experience, and he was so not willing to see the psychiatrist after that they never got a chance to prescribe medications to help him treat akathisia. So it just goes to show that having these conversations up front, sometimes you can't touch on every detail, but it just highlights how important these conversations are up front to explain what akathisia might be, what that might experience. It is an unpleasant side effect. We do have some treatments for it. If you experience it, let's figure out how to work together to make you more comfortable. I'm not saying that this wasn't done in this particular case, but it just goes to show that, a longitudinal open conversation with the treatment provider is going to, potentially, but could potentially have improved that outcome.
Mm-hmm. Thank you. And just to piggyback a little bit on that, could you speak to the psychology of medication noncompliance in terms of how do we understand it, and then also how do we move beyond it?
Um, so, I mean, non-compliance with medication is very common. Um, I mean, I think that not to say that anybody's being misleading when they're coming to their psychiatrist appointment, but if a patient says they're 100% compliant with their medication, I know they're incorrect, because no one's 100% compliant with their medications. They can tend to miss their medications from time to time. Um, uh, what can be difficult is purposeful um, uh, uh, avoidance of medications due to side effects, due to stigma, due to having had I've had patients that have had psychotic symptoms for so long that when they experience lessening of psychotic symptoms, it's sort of a different world for them, and it is sort of uncomfortable to a certain degree. That can lead to non-compliance. I mean, I think that non-compliance is going to exist, but the way that we move forward is, continuing to work on treatments and medications that reduce or minimize side effects, and then also continuing to have those difficult conversations about side effects and what one may experience. Because, if I have a conversation with a patient and say, like, hey, I'm concerned that you might have, akathisia on this medication. If you experience this, I want you to know that, we'll try and deal with it together. There's always other options for medications, rather than a patient experiencing, a negative side effect with the medication and stopping just because they're not aware that there's other options, or they feel that all the other options are going to offer the same potential risks. So I think it's a shift, continuing to shift how we think and talk about medications and treatment.
Thank you. And our last question, there were multiple questions around training and SMI. So how can we as a field get a broader and deeper training on SMI into graduate programs for clinicians and therapists? My graduate program had very little information on SMI. And then in addition, people are asking what other training resources are out there for today for current folks in the field.
I'll add a little bit into that, and Dr. Lowden, you can add if you'd like as well. We have a couple nice resources that we, both of us really like, are the SMI Advisor, which is, I think, sponsored by the American Psychiatric Association. There's a lot of online learning opportunities. We talked about the Illness Management Recovery Manual, which has a SAMHSA curriculum. I also would like to plug that the American Psychological Association has a curriculum that is about recovery and serious mental illnesses. And I believe it's about maybe 8 to 10 different sections, and it covers a lot of this information. Lastly, toward being into graduate schools, I trained at the Illinois Institute of Technology, and I trained in psychiatric rehabilitation, sort of pre-doc, but IIT is one of the few programs that does that in the country. But I went there specifically to go and learn about that from, during the pre-doc. Most folks learn about that at the postdoc level, especially as psychologists. There are other attempts to have, professional board certifications, but I don't think those are done yet at the ABAP level. So those are things that are ideas that people have put out there, but they're not ready.
Thank you. Thank you so much, Dr. Michaels and Dr. Lowden. That is all the time that we have for questions today. Again, if we did not get to your question, please feel free to send us an email at webinars@rogersbh.org, and we will follow up with you. Before we conclude, I'd love for our presenters to highlight maybe a couple of takeaways from the presentation today.
Thanks, Genevieve. We just want to highlight 3 major things here. Serious mental illnesses goes simply beyond treating a diagnosis. As we've talked about today, things are very complicated, and we need to have a complex and multifaceted approach. Certainly, incorporation of family and having a multidisciplinary approach would be very advantageous for wraparound services. Psychopharm and psychosocial treatments in concert are really going to offer the best chance. We are big proponents and have looked at a lot of research that suggests that early psychosis intervention would really benefit people who are struggling with psychosis. Definitely in different states, it's very difficult to access those resources, but those would definitely give people the best chance at managing that. Finally, how we show up with patients makes a huge difference. We can be the beacon of hope, or we can be the thorn in somebody's side, depending on how we approach things. But how we work with people promotes positive outcomes. And lastly, we just want to highlight that shared decision making is really like an instrumental part of this, and really having collaborative treatment goals that allow people to take personal responsibility for their recovery, so that they will take that human agency and be really empowered to move forward with their plan to own it.
Thank you both very much. And that about concludes our presentation today. Just a couple of housekeeping pieces. Within the next 30 minutes, you will receive an email with a link to the PDFs and also to the resources, and that will go to your personal dashboard on CEGO. For those who met the time required commitment today, you'll be eligible for the CE credits. You will also receive that link to complete the evaluation for today's presentation and download your CE certificate. If you have any questions about this follow-up email, please contact support@ce-go.com, and our community liaisons are looking forward to connecting with you about your practice and to help you understand any additional treatment options here with Rogers. On behalf of everyone at Rogers, we look forward to partnering with you and helping your patients. Thank you everyone for joining us today. Have a fantastic afternoon.